And
So,
We're saving you a chair, sorry.
I'll
We're saving you a chair. And are you going to be at the end? Oh, you're there. Yes, vice versa.
All right, you guys, as sad as it is to take away that nice lounge beat, I think we should go ahead and get started because we're running a little bit behind. Maybe the last couple people coming in could pull that door shut if there's still some noise out back. My name's Terry Reynolds. I see a lot of familiar faces in the room, which is fantastic. The people on the panel, I've put their names up on the slide here. It's one of these situations where most of them need no introduction, but I'm gonna do it anyway because it's fun. These are some of my favorite people in the world, friends and colleagues I've been working with for years. CUGH is the first person up here on the slide, right there in the black jacket. She's the incoming president of the African Federation for Emergency Medicine, also the head of education for the Western Cape Province government in Cape Town, and also at University of Cape Town as faculty, and I just gave up listing her affiliations because there's too many. Eric Gooseby, most of you in the room know. He's the Director of Global Health Delivery and Diplomacy at UCSF through UCSF Global Health Sciences, also a professor of medicine. Also happens to be the UN Special Envoy for Tuberculosis and kind of grand poobah of any number of other things. Henry Sawe, a fantastic friend and colleague for many years. He's the president right now of the National Emergency Medicine Association of Tanzania, also the head of emergency medicine at Muhimbili University of Health and Allied Sciences, where we worked together for years in Dar es Salaam in Tanzania. And then Lee Wallace, incoming president of the International Federation for Emergency Medicine, head of emergency medicine at University of Cape Town, and also head of emergency for the Western Cape provincial government in Cape Town. I was at UCSF for years. I am still affiliated as associate professor, but my primary job right now is at WHO running a program called Emergency Trauma and Acute Care. It is in a department with an impossible name, which I will just leave to you to read. Basically what happened is the injury department at WHO merged with a department for the management of non-communicable diseases. And once you had injury and non-communicable diseases in one place, it became clear that emergency care was a sort of integrated platform and made a lot of sense to address things across the department. So that's what this program was formed. It was almost formed out of the merger of this department. There had previously been kind of trauma care and injury care because it was an injury-only department. With the merger, the broader umbrella of emergency care emerged. So what I'm going to do is I'm just going to speak with a few slides for about 7 or 10 minutes and try to frame things, aspects of this discussion, and then each of these guys is going to speak to their organization and the level at which they've worked on these issues. We have an unusual set of triangulations here between universities, professional societies, and WHO, and all of us have worked together for years on different levels of this, and I think it's been a very interesting model for implementation. So that's the overall frame of the conversation we were thinking we would have today, and then most of the time will be left for you guys to ask questions, and you can redirect it in any way that you think is useful. We'll try to tell you about some of the things we've done together, but then you can take the topic where you think best. So emergency care, first of all, it sort of depends. A lot of these talks I give, I'm preaching to the choir, and it's people who already understand what that is. Other times I'm speaking to more of a public health audience or a broad system audience who's kind of like, well, what is emergency care? Like, haven't we covered that once we've treated malaria, once we've talked a little bit about surgery? Haven't we finished? And we really haven't, and I'll try to convince you of that, and there's a couple of examples I'd like to use. So my mandate from a WHO point of view for emergency care systems comes from World Health Assembly Resolution 6822, which was informed by this report. It was called Emergency Care Systems. And for the purposes of that report, emergency care covers a whole bunch of things, from pre-hospital care all the way through to in-hospital, which gives you an awfully broad frame of action and makes it a little bit hard to cover. There's a couple different things that I use to think about this. So this is an article on acute care that actually Emily Calvello, I think is in the audience, was one of the main authors on, and that's another term that is sometimes used. This is a definition that is kind of a functional definition of acute care, which is kind of unexpected, urgent, emergent, things that become worse problems without rapid intervention. There are also things where the interventions that you have available to you work less well if delayed. So that's one of the things we use to think about it. What I think is very important about this term overall, and the way that I tend to approach this, is when I'm talking to people who haven't been living in countries where emergency medicine is a specialty, where emergency departments are widely available, one of the things I use is like, okay, so if you fall over in the world, you fall over on the street, and it's either because you were hit by a bus, because you had diabetic ketoacidosis, because you had a heart attack, whatever the cause was, you fall over on the street. In most places in the world, there is no one who's going to come get you. And if someone does come to get you, there's nowhere to take you if it happens to be nighttime. So just the simplest idea of emergency care is the idea that if you fall over in the street, somebody should be able to come get you. There should be a system for that happening. There should be someone to call, and there should be a place to take you with providers trained in basic emergency care 24 hours a day. In most places in the world, that doesn't happen. That's not available as a formal system, but aspects of it happen all over the place. The other thing is most of the people in the world, make no mistake, that are delivering emergency care worldwide are not doctors. So that's another reality that we need to deal with when thinking about this. So luckily for me today, the SDGs are kind of a fait accompli. Like we have them. We don't have to talk about whether we like the SDGs compared to the MDGs. We don't have to talk about the problems with the indicators that have been chosen. I'm just going to talk to you about, now that we're in this SDG thing, look at the indicators in particular that are addressed well by integrated emergency care systems. First one, reduce by 3/4 the maternal mortality ratio. This one is pretty straightforward for most people. You can treat these directly in an emergency department. And I'll tell you, we didn't even cheat for this. So we've got these SDGs directly addressable by emergency care without even cheating. There's a few others where we could have cheated and said emergency care does something for them indirectly. Reduce by 3/4 the under 5 mortality rate. Most of this, so it depends on what you're looking at, but if you're looking at, say, tertiary facilities in Africa, at least 1/4 of the people presenting to the front door are children. Many of them are young children. This is the bread and butter of emergency care really all over the world. Diarrhea, pneumonia, kids who need a very simple, like sometimes they need 4 to 6 hours of treatment. Sometimes they might need 24 hours of treatment, maybe even 48 hours if it's bad, and they live for 80 more years. So emergency care is really the main way of addressing these kids who come to the front door. Reverse the incidence of malaria and major diseases and ensure that deaths caused by these diseases are reduced by half. This was a really controversial one for a lot of people because there were a lot of infectious diseases mixed in there. The truth is, the way people die of infectious diseases and the way people die of HIV is sepsis. And sepsis is part of the bread and butter of emergency care. When you come to the front door, the care that you're getting to start your treatment long before you know which one of those diseases you have is emergency care. It's how you get resuscitated. It's how you get broad spectrum antibiotics. It's how you get antimalarials. This is happening at the front door. Reduce by 1/3 premature mortality from NCDs. So heart attacks and strokes, this is the best thing about television, I have to say. The thing that has probably done more to explain to people what emergency care is television. Heart attacks and strokes come through the door all the time. The difference is, of course, they all get shocked on television, which often isn't the right thing. But emergency care, the front door, whether that's happening in a formal emergency department or not, heart attacks and strokes, the interventions that make a difference once you've had the acute event. Many of those are happening in the emergency department. Strengthen the treatment of substance abuse. This is something that doesn't necessarily come to mind, but we do an enormous amount of treating substance abuse, and both in terms of, there's a couple of different things that I want to look at here. One is the acute treatment of overdose. The other, though, is the emergency department population is a setting for prevention activities, is a setting for screening and prevention activities. That has been incredibly effective around substance abuse and a few other issues such as violence and HIV risk evaluation. This one I'm going to spend a little bit more time on because it's an easy example to talk about a couple things that are relevant to all of them. And this is actually, I apologize dramatically, and we get in so much trouble because there's a mistake in that slide. It's not 2030. This is the one of the agenda that is 2020, where the target is 2020. And that's why I was going to focus on it for a minute. So this comes out of the UN Road Safety Collaboration and the Decade of Action on Road Safety, which was already in place. And that is why this, and I see Barclay grinning because he's the one who made this image. That is why this one is 2020. And I just want to point out something to you, and this goes for every one of the things I've talked about so far. Make absolutely no mistake, prevention is better. Prevention is better, prevention is better, prevention is better. There's nothing I can say it is probably the most important message you can take away from the fact that emergency care is a great solution if you haven't prevented. So especially when it comes to road traffic injuries, there's all kinds of fallout from road traffic injuries, even when people survive them, and it would be much better if it had never happened. However, to give you a sense as we try to meet these SDG targets, the target is reduce the annual fatalities by 50%. Right now, that number is about 1.2 million. So what you're aiming at reducing, you're trying to save 625,000 road traffic injury deaths per year. Okay, that's the target for the SDGs. Now, if the rate of survival from severe injury were the same in low and middle income countries as it is in high income countries, not in a perfect world, not on Mars, but in this world, in high income countries, if the fatality rate, the survival rate from serious injury were the same in low and middle income countries as in high income countries, this is the number of road traffic injury deaths you would save, you would avoid each year. Now, I can't emphasize this more. Make no mistake, the people in red, if we save them, their lives would be saved. However, they have all kinds of physical and psychological fallout. So yes, as many of that red circle as we can handle by prevention, that is better. However, I put this up to show you that as we try to meet these SDG targets, the order of magnitude of what you can achieve with care is about the order of magnitude of the entire target that we're trying to reach. So we won't get all of the low and middle income survival rates, all of those systems to the level of high income systems, but we would be foolish to ignore care as one of our primary mechanisms for addressing this SDG target. Universal health coverage, this is one of the things that I find the most challenging is being in discussions about universal health coverage and not having the explicit presence of emergency care or acute care. So it would be wonderful if most of the world, if all of the world had the vision of primary care that was put out by Alma Ata and that is widely circulated now. However, what's happened since Alma Ata is there's been a reduction of it where it's come to be seen as only longitudinal care. I will often hear people actually oppose in their speaking primary care to emergency care or primary care to acute care, and I think that's a big mistake. So most of the world, because of financial and logistical barriers to care, because it takes a lot of energy, money, and effort to get to care, most of the world goes to care, accesses care when they are symptomatic with a complaint, and most of the world is forced to see a provider with whom they don't have a longitudinal relationship. So I would argue that acute care, emergency care, is actually the most common point of entry into the health system. I don't oppose that to primary care. I see it as a key piece of healthcare, universal healthcare at the primary level. But we ignore that at our peril because what's happened a lot in the last few decades is creating system architecture and approaches as we try to achieve universal health coverage and as we try to achieve what we call primary care. where the model is entirely about longitudinal care, and the failure to acknowledge that reality means that our system planning has got a profound mismatch with our implementation, and it is costing us. We are failing to meet the goals that we are trying to meet about coverage availability for people in the world. And part of that is due to our ignoring the role of acute symptom-based complaint visits to providers where the patient, the person presenting, doesn't have a relationship. Treatment to acute exposures to hazardous materials. We've seen this a lot. Those of you who have worked in other parts of the world, I don't know how many times you've seen especially pesticide-related poisonings that are very acute and life-threatening. The data on this is really, really challenging to synthesize and represent, but it is entirely possible that tox exposures and tox ingestions are the most common reason for critical care admissions around the world. Another one, disaster preparedness and response. I spent a lot of my time saying, no, not that kind of emergency. So especially at WHO in a very high-profile way recently, right, has been doing a lot of work on emergency response. So I spent a lot of time trying to explain that I do everyday emergency systems, like on television, and not earthquakes and tsunamis and such. However, the incredibly important piece of the longitudinal emergency system is its ability to withstand a stressor. This was mentioned in the keynote in the opening today. One of the things that happened in the Ebola epidemic is the secondary mortality from conditions that were previously treatable, like pneumonia, diarrhea, asthma. Because the system collapsed in response to Ebola, there was more mortality from diseases that were previously treatable than there was from Ebola itself. And so the idea with the everyday emergency care systems is to build them, one, so they're resilient enough to withstand stressors, and two, so that they're prepared to surge and respond to those stressors. The other point that has to do with response is you need a plan. You need the basics of how to build an emergency care system so that you have, in what is now being commonly called the early recovery period, so that you're able to rapidly reestablish acute care services. Last one, significantly reduce all forms of violence and related deaths everywhere. Many of the aspects of treatment for victims of violence have already been embedded in the things that I've mentioned about emergency care in the past, treatment for injury, but also treatment, screening for danger signs, and treatment of acute psychiatric and mental health presentations. These are the targets. I'll put these up again. I want to run a couple more things past you. So the way I had mentioned that we're going to structure this is talk about these professional societies at the level of the international, the regional, and the country. And a lot of our collaboration has been specifically around the initiatives from this WHO program. So I'm going to take you really quickly through 3 or 4 of those. And then there's a few more that Lee's going to mention later. When I first took this job, it was a surprise to me that there wasn't actually a document anywhere. Like when I would talk to ministers, they'd be like, that sounds great. We need emergency care. Wait, what is it again? And like, wait, what's included in that? And everybody has a different idea, and so it was a surprise to me. There wasn't really a document that gave you a strong, central, internationally agreed kind of definition and scope of what your emergency care system was, and if you were a minister or policymaker, like how would you go about addressing it and acting on it? So this was one of the first things we did. This is a document that's been reviewed. This isn't meant for you to be able to read the small words. I'll show you those closer in a minute, but this is a document that's been we went through a series of regional meetings, several of them you'll hear about in conjunction with these societies. And then we also had kind of a global ratification meeting, but overall it's about 32 country input to this. And the thing that blew me away was that at the beginning there was argument and we had to refine and there were distances. I really thought we'd go into this and we'd get something from Africa, something from Asia, and kind of choose a middle road that everybody could at least accept. But instead what happened was at the beginning, there was discordance and we would have to refine things and change them. We went through this square by square with all these countries. And by the end, even though there was a series of countries that were really disparate, there's a couple more African countries, there were several in the Western Pacific region, there was absolutely no argument near the end. There was less and less argument. So I believe in this more than I ever thought I would. We actually managed to converge on something that is a set of essential functions of emergency care systems. This is them a little bit more close up, and sorry, I forgot to mention one thing. There's a lot of buttons on here. I'm going to guess at the one. There we go. So what you see on the left axis, there's scene transfer facility, and this goes down, locations. Across the top are the WHO health system building blocks. There's plenty of different frameworks you might use for that. That one works as well as any. These are some of the functions. This may seem obvious to you, or it may not, depending on what area you work in, but I'll just give you one example of what the meaning of breaking it down in these kind of functions was. With transfer, it turned out to be really important, people felt, and there was 100% consensus on this, to separate it into two functions, transporting the patient and caring for the patient. That seems pretty obvious, but what happens when you carry it across the framework is that means you have two different slots in the human resources. You have to have somebody who's driving, and that can't be the person taking care of the patient. And it doesn't count as having all the essential aspects of emergency care if you don't have both those functions fulfilled. Now, that doesn't mean you're not doing anything useful. There's a fantastic example of a motorbike ambulance program which is a little tricky now that I work for the kind of injury, prevention department as well, to recommend motorcycles. But the point is, this great initiative is going on. They send a trained provider out on a motorcycle to a woman with complications of delivery. The person is a trained provider, they deliver scene care, okay? And then they put the woman on the motorbike and transport her. So they stabilize the person, put her on the motorbike and transfer her. So in that case, what you achieve is you get a dispatch, you dispatch your provider, you call, you get to activate the system, you get dispatch, you get a provider response, and you get patient transport. What you don't get is transport care, and that's the value of dividing this into functions, is they can look at that and say, okay, you know what, we're doing really well on these functions, it's not nothing, but we need to improve on those functions. So that was the idea of this. Overall, the other thing is it's incredibly important to recognize and make use of what you can't just say you need shiny ambulances. Like that can't be your starting point. And I swear to God, the word that most makes me want to engage in interpersonal violence myself is helicopter. The number of people who I say emergency care globally and they say helicopter. And they want photographs with helicopters, and they want helicopters. I'm not going to argue about the value of helicopters in some situation, but let me just make a much more conservative statement that there are many, many, many places in which helicopters are not the right next step. So the point is, you can't expect the pretty, shiny, fully fledged emergency system in a box. These emergencies are happening every day, whether or not you have an organized system. And the introduction of system architecture and an emergency care system framework can take a lot of aspects that are already there. All over Africa, people are getting to the hospital every day. They are getting themselves to the hospital, and there are many, many, many different ways to make that process more effective, more timely, and safer. So the point about the framework is to engage these activities that are already going on. To that end, this is a linked assessment tool. I show you this in its online form. And then this is it in a paper form. This is something we're doing in a lot of countries across the world. And for any of you who are working with partners in country who you think might be interested in this, I'd be happy to hear about it. The idea of this is instead of doing a checklist where you say, we have this, we don't have this, because then if you say no, what do you do next? This is an emergency care assessment tool meant to be used at the national level with progressive answers. So if your answer for a particular domain is 1 or 2, then the natural, most likely to be feasible next steps for development and for improving towards a more efficient, more effective version of that element would be 3 or 4, would be above. We just had a great experience, which Barclay Stewart, who's here, coordinated, of running that in Ghana. And we have a few other countries with that going on right now and are looking to launch it pretty broadly in the next year. The other thing we have is a basic emergency care course, thanks to heroic efforts by several people in the room, but especially Heike and Andy Tenner were really leading this. This is a simple, concrete, very visual, interactive workbook. There's a participant's manual and a facilitator's guide. It's aimed at mostly non-doctor providers who are working below the level of a district hospital. So pre-hospital providers, clinic providers, even undifferentiated district level hospitals if they don't have any specialists around. Very action-based, and that's one of the things we've been working with. Another thing, the WHO minimum data set for injury, and then I'm very close to the end here. This is the reality of the world. We have an injury event, a trauma care system, and an outcome. Then you can take care data, event data, and outcome data, which are elements that go into a minimum data set. And from a minimum data set for injury, you get to identify risk factors and inform prevention efforts, hopefully reducing this. And then you can also take outcome data and feed it into your trauma quality improvement activities, hoping to make this trauma care system to outcome link better with improved care. Among the aspects of facility-based trauma care, we have a WHO trauma care checklist. It's shown in a huge multi-country study, showed some real impact on process measures, like how quickly people were getting care, et cetera. But there's some work going on in Ghana as well now, where it looks like there may be quite a large impact on clinical outcomes as well. This is just one last thing I wanted to bring up. Day before I left was World Health Day, which is the birthday of WHO, the anniversary of WHO's foundation. And every year on World Health Day, they focus on one particular event or aspect. This year it was diabetes, and we launched the Global Report on Diabetes. That was cool. It's also in our non-communicable disease department. So like I was there, I was engaged in it. But I thought of it as something, I was there for my department, not, I treat a lot of diabetes, but not central to how I think about things. And they had two speakers, which was an incredibly smart thing. One was Florence Banda, who's a young woman from Zambia. And the other was Maria Fabiana Bria, who is a young woman from Argentina, but works at WHO. She's administrative staff at WHO. And they told their stories of feeling sick for a long time, going to the doctor, and then finally finding out, both of them, not as young children, both of them as kind of adolescents, young adults, that they had type 1 diabetes. And they talked about their care and their challenges, and it was just very compelling, the two systems put up against each other, because Florence got all of her care in Zambia, and Maria had been cared for in Switzerland. And the thing that was the most compelling about it to me, though, was that they were both emergency room stories. So Florence told the story. She came to the doctor in a little emergency unit, and she was feeling bad, and they treated her for malaria. And she went home, and she dutifully took her malaria medicine. She didn't get any better, so she came back to the doctor. And so they looked at her, they examined her, they did a few things, and they treated her for malaria. And Maria's story instead was she's like, I went to the emergency department over at the University Hospital, and they looked at me, and they did a couple tests. They said, oh, you have type 1 diabetes. And then she explained how her care had gone from there. They talked about the relative availability of insulin, all of these things. But for me, it was an incredibly compelling story of why I care about emergency care. So patients don't know that they have diabetes. I can't say this enough. There's a lot of problems with the vertical disease agenda being used for everything, from thinking to funding to everything else. Ultimately, don't get me wrong, the disease-specific care and the more targeted the care can be to the disease, the better. It's a wonderful thing. All of the research that we've done to better treat specific diseases is fantastic. But that is the end of the story. So the thing I can't emphasize enough is they come to the door, and whether you're in Switzerland or Zambia, they don't know that they have diabetes. They don't know that they have a surgical condition. Patients don't know what they have, and that is the role of emergency care. And that is, everyone's talked about the SDGs being a fairy tale, either a good one or a bad one, and that might be true, but just don't ever forget that emergency care is the once upon a time part of it. It's the beginning of the story that everybody, everywhere, no matter what disease they have, needs to start the story. The diagnosis, the intervention, the definitive treatment is the end of the fairy tale. These are the SDG targets, and I'll leave these up there, and I'm going to give each one of these guys a chance to speak now. Maybe we should, why don't we start and go Hendry, Heike, Lee, and Eric. Thank you.
Thank you very much, Terry, for such a wonderful introduction. So, as Terry pointed out, I come from Tanzania, and my primary job is with the University of Health and Allied Sciences at Muhimbili in Dar es Salaam, which is the main commercial city of Tanzania, a country of about 45 million people, where HIV is still the leading cause of mortality. So with my primary job at the university, I serve as the head of the Department of Emergency Medicine. And in that role, the aim is to train people to save emergency care systems, but we realized quickly that we can only do enough with training of emergency medicine physicians, which is just going to be a handful. And following that, we decided to pioneer emergency care across Tanzania because over 70% of Tanzanians lives in rural places, and many of these physicians we train are not going to be able to serve in those places. And so we decided to found an association, which is, I feel proud today to be a founding member of that association, which is the Emergency Medicine Association of Tanzania. With the main aim of the Emergency Medicine Association of Tanzania was to pioneer the emergency care systems across the whole of Tanzania. why this association was formed is, as I said, the association aims at reaching to the very rural places. And so for it to be more effective, we needed to partner up with different organizations. And as Terry has pointed out, among the areas that the association have found this partnership to be very useful is through the piloting and implementing some of the initiatives that the World Health Organization has done. Just to point out a few, the basic emergency care course that the World Health Organization have pioneered was piloted by the Emergency Medicine Association of Tanzania in Dar es Salaam and in other district hospitals. And this is very important because most of times we get these causes that comes up from higher levels that have not been piloted to the very lower level. And the causes are very nice when you look at them in the books, but when you try to implement them on the ground, they usually fail terribly, and we have several examples of those. And I think that the initiative of WHO partnering with country association or implementing partner at the very lower level in some of these causes and also some of these tools will really give the World Health Organization and any other organization an opportunity to really understand what will work on the ground, more so than just what will work on the theory. The other two areas that have been really, really useful for the association in Tanzania and the emergency care system in Tanzania at large is the emergency care assessment tool, the tool that the World Health Organization put forward to assess the trauma systems in the country together with the general emergency conditions that happens in different places. These are still under pilot in Tanzania and other countries across East Africa. And involvement of people at the district level and at the health facility level is the ones which is going to guarantee the success of these causes. And so through that whole partnership with the institution, Emergency Medicine Association of Tanzania now works with the Ministry of Health collaboratively to implement what the Ministry of Health wishes, and also the Ministry of Health works closely with the World Health Organization. And on the other hand, the Emergency Medicine Association of Tanzania also works with the regional body, which is the African Federation of for Emergency Medicine, AFEM, which Heike is going to talk about in implementing this vision across Africa at large and sharing those experiences that has happened in Tanzania and many other African countries. AFEM is able to come up with an agenda that can cross-cut in all the African countries, and that's how kind of these bodies works together. And with that, I'll also like to let Heike speak a little bit about how AFEM have implemented some of these things across Africa.
See, we even share mics. It's awesome. I just want to make a little statement saying that it's midnight in Cape Town. So whatever I say, please forgive me. I should be asleep. So when the African Federation was formed, it was formed in Cape Town in 2011 as part of our 2009. I'm starting. It's been a long 5.5, long time. 2009. I take it back. Well, it started because what we were finding is that there was a lot of activity around emergency care development going on across Africa, but it was all happening in silos. So there would be programs that were doing interventions about 100 miles from another academic program, doing a different intervention, duplicating resources, and not actually developing regional or countrywide progressive development. And we found that we needed to find some way to bring all of these organizations, academic groups, interest groups together and find some common goal and start sharing resources so we wouldn't be constantly reinventing the wheel. So everywhere you go, people were creating the same training programs and guidebooks and handbooks and liaising with ministries and developing different programs. All we were doing was just either stepping on each other's toes or not moving the entire region forward. So we started with 7 organizations and some special interest groups. And one of the first things that AFEM wanted to do was to encourage these groups in countries that didn't have emergency care societies yet to form societies to be able to drive it forward. And that was one of our first initiatives, was to take these groups and try and formalize them and link them into AFEM. And I see a lot of the people that were there about bringing AFEM and African development forward in this room, which is fantastic. And that's another little side thing, is that it's about the people. AFEM was definitely about the people who wanted to make a difference. and to create a way for them to network and streamline and to work together. And from 2009, I think everyone's still on the same road, which is fantastic. One of the key things, particularly around emergency medicine, is during that founding moment when we spent a lot of time trying to decide what AFM would do, we actually spent probably a couple of hours deciding what AFM would be called. Because there's the concept of emergency care, and Terry's been very clear that this is emergency care, but we were going to be AFM and not AFEC, as Lee was mentioned. So that is an important thing. We want to be inclusive. We want to incorporate all of the different healthcare providers involved in emergency care. And that just doesn't mean physicians or specialist emergency physicians. Because in most of Africa, healthcare is given by nurses, it's given by clinical officers, it's given by community health workers, by people with little training. And they are the emergency care workers who will drive emergency medicine forward. We decided on emergency medicine because it was felt that everyone could fall under the umbrella of emergency medicine, and it would be better understood by the people that we needed to work with, by the ministries, by the funders at that time. And maybe that's changed, and it's something that we will discuss as we go forward. But at the moment, AFM is an organization for not just physicians, it also includes nurses, out-of-hospital providers, clinical officers, and those are the people that we want to incorporate and drive the organization forward with. One of our biggest things about engagement, the most important things about the engagement that we want to do through a regional organization is to engage with the national societies, but also to engage with academic institutions. We have a very interesting model is that most of the people affiliated with AFM have strong academic affiliations as well. And there is no being torn between those two. This is where we are trying to align academic demands and academic projects with a greater regional or country initiatives so that we are all working in our own fields and in our own projects, but that the projects all align with a greater goal and that the projects all speak to each other. We share information, we share resources. Terry's been instrumental in generating the AFM resources. In the last 5 or so years, we've done a handbook of emergency care. We've done an open source curriculum. And all of these resources are open source. Because one of the first things that people have asked about this organization is, what can you give us tools that we can use to build emergency care? So we would like to continue in that direction. And I will speak to Lee, who is the outgoing AFM president, about our bigger vision for the world.
Thanks, Heike. Good afternoon, everyone. I promised Terry I wouldn't speak for more than an hour and a half on my bit. Moving from a sort of WHO vision to a national level, to a regional level, to the international or global level, it kind of maps my career over the last 15 years in Cape Town. I started in 2007 as chair of the National Society, and over 4 years in that role, sort of understood the role of a national society in helping to build an emergency care system in a country that actually has reasonable emergency care in parts and very underdeveloped in other parts. And then I've been with AFM since the beginning, 2009, and have watched and learned myself as AFM's gone in somewhat different directions and either been driven by or pulled people along in that direction. And now I've been involved with the International Federation for Emergency Medicine, IFEM, for about 8 years, initially on committees and then for the last few years on the executive. And next week I hand over AFEM to Heike and take over IFEM presidency. So I wanted to say a little bit about what IFEM is and then a little bit about what IFEM should be. My thoughts really on the role of an international society, and I would hope we can come back to the sort of role of a regional and national society in a little bit more detail, maybe with some questions. So IFEM is in its 25th year this year. It was started by the UK, Australia, Canada, and America, the professional societies for emergency medicine in those 4 countries, initially as a mechanism to host a conference every 2 years in one of those 4 countries. And the conference gained a lot of traction, and at the conference over, I guess, 16 to 18, 20 years or so, people started talking more and more about global emergency medicine work, international emergency medicine work, rather than just the conference. So over the last 8 or 10 years, IFEM has produced a reasonable number of products that talk about cross-cutting emergency medicine issues. So maybe a residency curriculum, recommended quality framework for emergency departments, a number of documents along those lines. But the underpinning theme for everything that IFEM has done for the last 25 years, and they've done some very, very good work, which I'm very supportive of, is being directed at specialist emergency physicians, which represents the high-income country founding and background of IFEM, and continues to be dominated by high-income countries. We have about 70 member countries at the moment, of which about 10 are very active within IFEM. And those countries are very active because, as Heike alluded to, it's individuals who've got time to commit. And those individuals almost inevitably who've got time to commit come from an academic background in a high-income country. So if you're at a US or Australian university and you have some of your time for academic activities, it's fairly easy to list IFEM as those activities. We do have a spattering of inputs from people who work in full-time clinical in government and so on, but it's harder for them to get involved. But a lot of the work is done face-to-face. A lot of it is done on Skype calls and so on. And even in Cape Town, it's hard to join in a Skype call with the US. The call will drop 3 or 4 times on a 1-hour discussion. So inevitably, we've been driven by high-income country organizations and academic organizations at that. Now, I'm not saying that that's a bad thing. It's just the reality of where IFEM has been. We have a strategic retreat next Saturday, just before we have Cape Town's hosting the conference that IFEM was originally founded around. And we have a strategic retreat for IFEM, where I've put on the table a new vision for the next 25 years, which is that while we retain the name, that we change our direction from worrying about emergency physicians in high-income countries. Many of you in the audience I know are emergency physicians in high-income countries. And with the greatest respect to all of you, you guys are not the problem for emergency care in the world. You're part of the solution. So the problem is, there was I forget the speaker's name this morning, in the introduction, there was a very nice picture, those of you in the introduction talk, of a clinic, like a clinic room in a low-income country, which was supposed to show the dysfunctionality of healthcare around the world. But actually, it was way better than what I'm used to seeing in Africa. There was a red hazardous waste bag in the bin. There was a monitor on the wall. It was spatially well lined out. It was a decent room. There was a clinical protocol taped to the wall. That is not the reality that in most low-income countries, healthcare providers providing emergency or acute care are used to. It's much better than they're used to. So the lived reality for the vast majority of people who seek emergency care across the globe is that they seek it from someone in a facility that wasn't designed for purpose, that isn't equipped for purpose by people who are not trained for purpose. So I think IFEM needs to, first of all, work hand in hand with WHO, and we have, for the first time ever, we have the opportunity with Terry at WHO. And secondly, to focus on emergency care, not emergency medicine. And thirdly, use our high-income country members, the 4 founding members, plus a lot of European countries, and there are a number of other high-income countries that are very active within IFEM. And we need to turn our attention to emergency care systems development. So there's a couple of ways that we can do that with academic publications and so on, all of which is minor detail, but there's a couple of very important ways we can do it with WHO. And the first one is we can provide technical input on WHO products, which we are doing. I'll come back in about an hour to when I finish speaking. I'll come back to the meeting next week, which we have, which is an input meeting. But the other way is that we can partner to coordinate regional rollout of products. So the basic emergency care course that you just saw, IFEM went through a sort of formal endorsement process for that, and actually we have our logo on the front page of the manual. So it's a WHO product that is somehow or other also endorsed by IFM, and it's now Terry's going through an internal process whereby they'll be, okay, we want to do this in 20 countries in this part of the world, and come to IFM as the coordinating body to work with our member national societies to achieve that. On the technical input side, we have a meeting in Cape Town. We've got representation of about 40 countries coming, and we're looking at 4 new products, which Terry had touched briefly on earlier. There's 4 new WHO products coming out, which we're at the sort of expert technical input stage now, and IFM's playing an integral role in that. And I think, well, I'll come back in a second to what those products are. I think this is the future for IFM. If we're going to be meaningful in emergency care going forward, we cannot be looking at refining more and more the fine detail of a well-paid, well-educated minority population, which is what we've looked at in the past. And I'm part of that population. I'm not knocking emergency physicians. Very important role, but 90% plus of emergency care in the world is not delivered by emergency physicians. So the 4 things that are coming up, which are very much high on Terry's agenda, which will be out very soon, metrics and indicators for emergency care systems. So we have a couple of processes around access indicators and quality, clinical quality indicators. Essential resources for emergency care. So if you're having an emergency care system within the emergency care framework that Terry showed, what resources must you have at first level hospitals and referral hospitals and so on. A consolidated chief complaint list so that you can actually start to compare data across facilities. So if people present with chest pain, how granular do you go with, are you talking about an ST elevation MI, or are we talking about cardiac chest pain, or are we talking about chest pain as a group? And there's been a lot of work done by different groups that Terry is now pulling together to try and get one consolidated chief complaint list. And then the final thing is a minimum data set for an emergency care visit. So when facilities are starting to collect reasonable data on their emergency work, having a standardized list of, a standardized set of data that they would collect that maybe it's something about time from arrival to a provider or whether triage was done, indicators like that. I do think there's one SDG that's missing, just as a last point, which is, it's not emergency care specific, but SDG 17 talks about partnerships, as you will have seen this morning. And I think what Terry's spoken about a little bit, what Henry's talked about, what Heike's talked about, and I hope what you have got from what I'm talking about. Partnerships in emergency care, partnerships with important organizations like WHO, but partnerships between universities, between national societies, regional societies, and international societies are what's going to drive scale up and roll out of emergency care system improvements. And I'd encourage all of you, I understand if you work in an academic environment that your job's grant funded and you're dependent on competitive grants. I understand that won't ever go away. But I would really encourage, as a final message, collaboration. It's the only way we're going to make a significant impact towards the SDGs. Thank you.
Thank you. Well, thank you very much. I think that the discussion has really highlighted a number of issues that I think the universal health coverage goal has presented across the vertical disease portfolio, infectious diseases in particular, and also for what I think is in many ways the point of entry for most of the patients that get in front of a appropriate diagnosis and treatment. The collaboration that I think is reflected in my colleagues on the podium is unusual, and I think we should just take a second to acknowledge that the ability to find the support that the basic public health system that is the primary entity responsible for orchestrating the response needs to identify kind of what are the determinants of a optimal response versus an acceptable response. How does that response reflect on itself a trajectory of improvement? How do information systems within the context of that delivery system for that emergency response in any given region of the country, position itself with surveillance information, outcome information that enables the decision makers in that facility and referral system to understand impact, and with that understanding, in the next budget cycle, make the adjustments that improve the ability to identify in a timely fashion, make a diagnosis, and initiate an appropriate treatment response. It is quite a cascade of knowledge that requires, and a filigree, if I could use that word, of handoffs that are unique in an emergency setting for the identification and transport of an individual, and acknowledging the distinction Terry made of the person who's responsible for moving the patient safely and attending to them in that moment of stabilization. And can movement transport occur in every system before stabilization occurs? Who makes that decision? And when it goes awry, what is the kind of institutionalized corrective action? But the individual site, the academic or freestanding center of excellence, or the, I would say, private sector component that we often don't think of. In many of the countries in which we work, the private sector has made the decision to take on medical care for its employees, and how that system may or may not be up and running from an emergency response standpoint, the parallels that are identifiable that can be taken advantage of, so parallel systems do not need to be created, that synergies can be identified and secured, or the current referral delivery system and the response can be intensified with those unusual partnerships. So academic freestanding centers of excellence, academic medical centers, or academic efforts, and I think, again, the understanding of the importance of engaging the leadership in the public system of care to be able to sustain the support systems that are identified in perhaps a demonstration project, but more importantly to generalize those solutions to the broader unmet need in regions or geographic areas where that response has not been developed. I think the international or multilateral approach sets norms, sets expectations, sets standards, but none of those will be realized unless there is a formal engagement in the public sector to implement the program. So everything at the multinational level has to be translated into a local process that has, again, a country-specific component to it, but also a provincial, state, district, and village component to it that needs to be explicitly defined, a cascade articulated that will allow policy and funders to understand where in that continuum of services their investment allows for the intervention or completion of that expected or desired cascade to impact the patients who are in need of the services. I don't know, Terry, if that's enough. Yeah. Okay.
So what I'd like to do now is just questions from you guys. Any of these topics that you'd like to address, or to any of the panelists, or to all? Questions on any of this? Yeah? And I guess if you want to come up to the mic, that would be great. And what we'll do is I'll sort of send one of the microphones around as well, but let's see if,
Thank you.
Giannis is young. Yeah, Giannis, now that you've become a full professor, can I get you to pass this around? Hey, Giannis, come here, professor. Are they fun to get? You happy? Okay. All right, just keep that in case somebody comes in.
So the emergency medicine field is working on improving the SDG goals. And a lot of this is based on statistics. My question is, how accurate are the statistics? If someone dies from this disease or does that disease, I mean, when Supreme Court Justice Scalia dies in Texas, we don't know if it's from a stroke, a heart attack, or a drug overdose. So if someone dies in Southeast Asia, how do we know if it's from malaria, sepsis, or non-communicable disease? These statistics we're using, how accurate are they, and how do we know they're accurate?
That sounds like a W2 question, man. I love this job. So what I would say about that is we're not, the question of statistics and characterizing the impact of emergency care is an extremely challenging one, and it's one we're working on a lot. There's two directions to look at that. One is kind of modeling around the global burden of disease and what part of the global burden of disease is amenable to or potentially treatable by or addressable by, or the terms that have been used, emergency care. And so it's been large-scale modeling like that. You're not going to get precise answers as to what component of the DALYs or of the deaths are exactly attributable to the emergency care system, because the best ones are highly integrated. So what we are trying to do to address this to some extent, the two ways that we've approached it are, one, looking at better models for what part of the burden of disease is addressable by emergency care. And then, because so far those have been based on kind of expert consensus decisions that take the global burden of disease or the global health estimates data, and they say, just a bunch of experts say this, and this are addressable by emergency care. And then you add up all the DALYs, and then those are the general stats we use. So that's okay, but it's not very precise. The other thing we're trying to do, though, at least achieve, is a good set of metrics and indicators so that when we intervene on the emergency care system, so when we train frontline providers or we establish a dispatch protocol for ambulances to make them work better, or you put ambulances in place, so at least we can see what the impact is. So I think that's what it'll be. It's never going to be the kind of specific disease modeling that you can have for a certain treatment or diagnostic test. I think the best we're going to get, and I think it's pretty good and will work for our purposes, is having good metrics and indicators so that we can follow the impact of our interventions. Yeah, because it's always going to be a multifocal bundle of treatments, approaches, system architecture, and capacity building and personnel. Does that answer your question, or is that a slippery workaround?
Both. So
Okay, both.
Sorry. Terry, can I just make a comment on access to data? Because that's one of the things that I think we've all mentioned is as at a local or regional level, when you try and plan interventions, you do need data. But often they are in low, middle income countries, there's poor data collected by ministries or health systems, and it's often done through small academic programs. And we share data in big conferences or on papers that are published, but that's not necessarily available or accessible to the ministries who have to make these plans. So this minimum data set that WHO is creating is really important, is having people buy into open sourcing data in some ways that'll make all of us much more effective, and trying to break down those silos again of holding on to what I've collected is mine and I need to publish on it. That's what we need to do.
This question comes from a pediatric emergency medicine physician. So I've trained in both pediatrics and in emergency medicine and have had some work in sub-Saharan Africa. I think you rightly pointed out in talking about the SDGs that many children who present to hospital either die immediately or they survive. Some studies have shown anywhere between 50 to 75% of children who present to hospital die within the first 1 to 2 days of admission. Even minimal refocusing of efforts to emergency care for children for medical illness has shown dramatic improvements in survivability at the level of the hospital. As an emergency medicine, pediatric emergency medicine physician here, we do both medical illness and trauma-related illness, but in places where I've been, the paradigm for pediatricians is not to take care of injured children whatsoever. You have a trajectory where injured children, trauma-related illness amongst children is going to overtake, or will, in many age brackets, has already overtaken the number of children who are medically ill. Yet you have pediatricians, or classically trained pediatricians, who have no input into neither the policies nor the care of injured children. So the specter is that the majority of children in the hospital potentially could be completely outside of the realm of pediatricians. What role do pediatricians have in taking care of injured children? Or as you think about the emergency care of injured children, what role do you see pediatricians playing in that? I think the model in high-income countries is we have subspecialty trained pediatricians, or through the emergency care training program, you have people who are trained to take care of both medically and trauma-related emergently ill kids. I don't see a model for that really on any scale in low and middle income countries. Wondered if you had some thoughts on where pediatricians have a role in this.
I don't want to answer it, but since you told me I have to, I will answer it. Thank you, Terry. That's a really interesting question, and I will probably should start my answer again by saying this is not to offend anybody in the audience. But pediatricians not looking after injured children is not the problem. Like, it's a problem at some facilities and a small number of children. I'll come back to my thinking on it. For sure, we need to have some solution for that. But the overwhelming majority of injured children are not being seen by a doctor, never mind a pediatrician, right? Someone goes through a 5-year residency program, half of them go overseas to somewhere where they can earn a salary and fulfill their base level of Maslow's, they need job security and money and all those sort of things. I think if you're a referral level facility, the reality is, and this is something I've been trying to grapple in Cape Town for a long time, our 2 tertiary hospitals have, for children, they have a pediatric medical and a pediatric surgical where trauma goes, and under a trauma surgeon, and we're trying to have combined, we talk about the inefficiencies and the extra costs, so we're trying to have combined emergency areas, and the pediatricians just say, but we can't see trauma. Well, okay, but I couldn't see trauma when I left medical school. You know what? Someone taught me. It was really easy. It's really not difficult to do. I think if we start to get this epidemiological transition, which is inevitable, then the only thing we can do at those facilities where there are pediatricians is start to use the workforce that we have, which includes pediatricians, to see the patients that we have. We have to do that. But I think that's pick a number, 15%, 25% of the problem. The rest of it is that generalist doctors or clinical officers they're trained on pediatric diarrhea, they're trained on pediatric malaria, they're trained on pediatric HIV. Nowhere in the training is injury, and that's a much bigger problem for me.
And I would say almost the same thing, in that this battle was fought with, most of the world doesn't have the luxury of redundant surgical and medical providers. And so this battle was previously fought for adults. And I would say the alternative isn't really subspecialty training. It's really to engage these profoundly smart doctors who have focused on children and focused their careers and their passions on children. And there's all kinds of pre-service and in-service up-training that can happen, because we need to acknowledge the frontline reality out there in the world that most of these providers are seeing children and adults with medical, surgical, and obstetric conditions. And we just aren't acknowledging that reality, that you need some group of people, you need a space dedicated to emergency care, and you need a group of people dedicated to getting people safely from the world into the hospital. And I would say it is that same simple argument, whether it's for adults and children. I think the situation for children right now in Wichita is particularly tragic, because you have these great committed doctors who, with very simple up-training, could be addressing these things. And they're the best at children's physiology, whatever was the etiology of that shock. They're not going to do pediatric trauma surgery, but neither are we. So, I would say actively engaging those pediatricians so the kids aren't peeling off. What's happening now is the really acutely ill kids are peeling off to a kind of pediatric outpatient department, which is in no way physically or otherwise, or process structured to be an emergency department. So there are things about this specialty that have grown up enormously over the last 30 years that I think are equally relevant to children and adults. And I would like to engage the pediatric doctors who are there to engage that.
And not just to prolong the discussion, but just to put some statistics in it. In a country like Tanzania, where we have 46 million, right now we have about 2 pediatric surgeons in the country. So Yeah, 2 or 3 right now, and all of those are based at the main national hospital. So you can see the magnitude of the problem. It will be more efficient if we train the local cadres like AMOs, COs, who are actually taking care of these patients, as Lee said.
So I'm the third one in the room from Cape Town. It's now 1 o'clock in the morning. So, and I also used to be a pediatrician. But I serve on the WHO Technical Steering Committee for Maternal and Child Health. And 2 rooms away, there are people discussing childhood survival. And they tend to focus on ARI, diarrhea, and HIV/AIDS. And the issues of children's injuries and the emergency issues related to children don't appear on that agenda. I did raise it at our meeting about 2 weeks ago. So you sit in the NCD silo, and Anthony Costello sits in the MCH silo. How do you come together? Because what WHO does has so much impact at country level. There's a lot of talk about the integrated management of newborn and child diseases through IMCI, but I don't see anything in there about emergency care. So, can you help?
Doing my best. There's a lot of internal and external advocacy that has been part of my job the last year. And I would say WHO is as susceptible as all of the global health organizations, including this one, to the paradigm dominance of infectious disease. And overall, it's heady stuff, right? You sort of, if you eradicate smallpox, that is going to, that's a profound sense of power, and that paradigm dominates for a long time. The other thing is with infectious disease, every act of treatment is an act of prevention, and so that's also got a kind of conceptual power. So working towards platforms and longitudinal care platforms has taken some work shifting that. It is, internally, we've had a lot of really good collaborations around products with those departments, and I was just in a meeting with Dr. Costello last week. So I think as WHO, we absolutely have to do better at that, and a lot of the way that I have been handling that, I've been messaging this to a lot of different departments. I think it is going to take quite a bit of time before products catch up, before messaging catches up, before thinking catches up. Because even in groups where I've had long conversations with people, not just at WHO, in universities and everywhere else, some of the people I admire most at this institution, in this organization, recently, who I've had many conversations with over the years, having grown up at this university, recently published an editorial about what we need for universal health care, including several components and not emergency care. So it's just, nobody's against it. This is the most important thing I would say to you. I walked into WHO thinking, they have not, in all these years, explicitly engaged emergency care. Therefore, there must be some powerful political resistance. So I was ready to kind of find that, work on it a bit, try to figure out a strategy. There is none. So all I can say to you is you showing up in that room and saying that, what I have found is every time I present it, people are like, whoa, great. Will you write that down? So all of these overall initiatives that should have emergency care in them, I have found no resistance. If you make it to the meeting and you say, hey, how about emergency care? How about the people presenting who don't know if they have an infectious disease or a hematologic condition? So that is all I can say to you. It's a huge problem. It is extremely widespread across universities, all kinds of organizations, and WHO, but do not project political resistance behind it, because most often it is not there.
Sorry, can I just add one? So Professor Jacobs was my dean for many years and was the person that encouraged and pushed me in my career. So I thank you for that, Marion. But I think the issue, your questions about WHO, but I think your questions are also wide. I know from our previous conversations, your questions about just about every national body, every international body that's thinking about, even if it's a funder, so we're going to fund malaria, it's a very vertical thing, or we're going to fund maternal and child health. And so the people they get in to talk about maternal and child health is the obstetricians and the pediatricians. So, I accept fully that it's an act of commission, not omission. Or whichever, the other way around. It's 1 o'clock. I'll get. So, and I've been drinking heavily all morning. So it's an act of. It's not willful. It's not deliberate. We don't like those emergency people. It's just they don't know. And when you engage people, they really do know. But I think the most important thing is to get out there and start advocating. We have a group in South Africa that's given a lot of money by DFID, the UK Department for International Development, to roll out ESMO training, so the emergency obstetric training. And I went to one of their board meetings in February. I got myself invited, and they've spent a lot of money, millions, over the last few years, very successfully training midwives and doctors in emergency obstetric care. And I said, so how many EMS staff have you trained? Do we need to train them? Who takes them from the, it's terrible. The care they get from the clinic to our facilities is terrible. Have you trained them? Do we need to? So it's just that people don't see that piece of the puzzle, even when it's that obvious, Larry, because the people that you're asking for advice are people who don't see that piece of the puzzle as part of their routine life.
Brad Dreyfus, University of Arizona and Global Emergency Care Collaborative. First of all, thank you. Thank you for putting this panel together, and thank you for acknowledging the role of mid-level providers in non-physician care. And I say that as a physician who's been working with a team to try and train non-physicians for emergency care in rural areas. Question for you all, how do we move from focusing on physicians in countries that are not used to focusing on non-physicians for specialty care? How do we do that effectively? How do we incentivize it and really move the needle? And thank you.
Wow, no one up here wants to answer any of these really easy to answer world problems. I'm first going to tackle global peace, and then I'll come back to your... I think part of the pride is... Okay, let me answer it from dealing with AFM and dealing with IFM and my experience of that. And this isn't, this individual is obstructive, but so these organizations are mostly run by physicians, and the people who do the setting the policies are mostly physicians, and the people who do the advocacy are mostly physicians. And we think about ourselves. Humans are a very group-oriented species, so that's what we do. And it takes a very willful, self-conscious act to step out of that and say, actually, the reality is, although we're all physicians in this room, we shouldn't be talking about us. And physicians are smart people, and they're used to being the top of their class and all those other things. So, and there's a personality type that goes with it. So it's hard to get the group that you're trying to. So let's have some non-physician providers sitting in the room setting the strategy and policy. It's quite hard to make that mental shift. But unless we push for it and advocate for it and are consciously aware of it, I think it's not going to happen by itself. It's not the sort of thing that will happen organically. Someone in each meeting, someone on each document that's been produced needs to actively stand up and say, where's the non-physician voice in this? Where's our thinking on it? Why are we talking about doctors?
My name is Sue Willard.
Oh, if I could just...
I'm a nurse practitioner, so I am the nurse. But go ahead, Eric, sorry.
I'm sorry. I was just going to say very quickly that the challenge is to put the mid-level provider in the planning and implementation discussion. That is predicated on them being in a position that is not volunteer but funded. So having that lined up before the dialogue is realistically going to hold their attention has to be kind of the prerequisite to it.
And I would also like to kind of echo that point very well, especially in most of these mid-level provider training. They do fail in low-income countries in Africa because of two reasons, if you ask me. Reason number one is anybody you try to train as a middle-level provider has two ambitions. One is professional development, and number two is financial incentive. And so if you train me for a certificate right now for something, if that certificate doesn't give me those two, eventually the curve is going to go up and then fall down. And I have a couple of examples in Tanzania where there are middle level providers which have been trained very well in anesthesia. So in my country, we have less than 20 anesthesiologists, so they try to train anesthesia mid-level providers. Initially, it failed because there was no recognition after training. You're just trained or called an anesthetist tech, and then there's no anything attached to it, and people kind of decided not to do it until when the ministry kind of started to recognize that. So for it to be successful, beyond the 2 points that have been spoken about, you need a political support. Each mid-level provider you introduce makes sure that the political recognizing body recognizes that training. Otherwise, it's going to fall down no matter what.
And I'd just add a couple of very practical things around that issue. One is definitely the CUGH has to be designated within the credentialing structure for two reasons. One, to assure payment and that they're getting paid for the work that they're doing, and that they have the peer group that is doing the same level of work and they're getting paid commensurably. But the other is for protections, because there's all kinds we saw during the HIV epidemic, the massive movement to task shifting so that nurses and other providers, non-doctor providers like clinical officers, were protected for the activities that they were actually engaging in. And so that's a huge aspect of this. The other, just two other practical things when making training things, like designating that as one of the targets is a big deal. Many of the training materials can be the same ones, many of them can't, but it doesn't matter. You need to designate within your scope, and if you need to train your training materials, change them. So this basic emergency care course is very much directed at non-doctor providers, was run by that, was piloted with those kinds of providers, and even internally the people running the program and implementing the pilots were nurses. And so that was a key piece of that one. The other thing, though, is that when trainings are created, even with the best intentions, like partnerships with the ministries and things, and you say, okay, we're going to put on a great emergency care training, can you tell us who you want to send to that training? Often the person sent is like the district medical officer who's assigned to the district who's doing an entirely administrative job. And so you need to actively negotiate and advocate to ministries not to send the person who on paper is the doctor assigned, because it's considered a perk. And it's a powerful thing to be allowed to do. They get sent to a training course, but they're sending the person who isn't delivering the clinical care. So one of our biggest practical negotiations has been with that. So whatever you have to do to negotiate out the idea that you want to partner in country, but you want to make sure that the people that you're asking to send you, the participants, are actually sending the people delivering care. And there are various ways to assure that. Mostly it just means opening the conversation and making it explicit. So.
Thank you. So my name is Sue Willard, and I am a nurse practitioner, Associate Dean for Global Health at Rutgers University in beautiful downtown Newark, New Jersey. One of the things that I have found over my long career, as demonstrated by my gray hair, is also the language of illness and the language of in the culture that we work with. So I'm not a mid-level provider. And when I hear a mid-level provider, I think, well, what does that mean? Is a primary care physician a mid-level provider to the cardiologist when he treats hypertension? So we need to think very carefully of our words, because then you're looking at the different tiers. Patients need care, and we're there, and we are trained to be able to provide that care. And yes, not one person, not one healthcare provider can provide all the care that's needed by a patient. We just need to know what it is that we know and do that well, and know what we don't know, and then move on to the next. And I agree, nurses can be invited to the table, and very often we're not. And it's really much of a challenge. But once we get on those tables, we need to make sure that the nurses also have the knowledge and the skills to be able to have the conversation, to have the data. And in nursing academia, we're trying to do that. It's always an uphill battle, but it's really important for our physician colleagues to work with us as colleagues and get us on those tables and advocate for us, because we just can't do it by ourselves either. So thank you for your time and for all of your hard work.
Maybe just one comment on that. That's a really important point. And Terry mentioned that in terms of, I'll use the phrase mid-level providers, accepting the limitations on it. But in many, many parts of the world, there is a very clear gradient between nurses and physicians. And while in the States and the UK, quite rightly, nurses have the same authority to have their voice heard, that isn't true in Zambia. And it's partly cultural, it's partly historical, it's partly system design and so on. So that also needs unpicking before. Very important that an experienced nurse from a US academic institution can have their voice heard, the same as a physician. But unless we hear the Zambian nurses' voices as well, then we're missing a significant chunk.
And I would say, I think conceptually, I understand when we speak generally of providers, we define. We're speaking of emergency care providers always. We never use doctor in our materials. When we invite people to the table, we've made very explicit efforts to make that better. What I'm still missing is the term mid-level provider is problematic, but I don't dislike it quite as much as I dislike the term non-doctors. So non-doctors is almost a defensive response to people who think you're only, talking about doctors. So I can't come up, and I welcome your input into trying to come up with a term. It can't be nurses and it can't be clinical officers, because just in East Africa, we looked at what terms were being used for the person we're talking about, and it was clinical officers, nurses, medical officer, and then a couple of more esoteric terms that were not used in more than one country. So I really welcome your input on thinking about this, on what the positive formulation would be. It's easy enough to do the negative one and say they're not doctors, because I've had to use that in a few documents lately, and I don't have anything except a very awkward solution to it.
Just to quickly, Terry, PEPFAR, who'd had a huge task-shifting agenda, used provider.
I'm trying to figure out how not to have people mistake that for doctor. So we use that in all of our writing, and then we need something. So lately I've been saying non-doctor to make it clear that, but that's,
Michelle Nashrenko from Boston Children's Hospital. I'm also pediatric EM, but dabble in the general EM world. I wanted to thank you for the structure that the organizational levels that you represent, from the national to the international. When I think about the regions, though, and applying this structure, Africa's, when I are less savvy colleagues, we often have to correct and say Africa's a continent, not a country, or Asia is a collection of countries, not a country. And within Africa, within Asia, there's a huge disparity when you take a Liberia, Sierra Leone to a Tanzania, South Africa, or Kenya, or a Laos to a China. And when I think about myself and many colleagues in the room who've spent a lot of time in West Africa, it's a challenge to work in these low-density physician countries, because their patient care are truly accessing at acute care points like you described, but there's such a low physician density, not more than 20 specialists in the entire country of Liberia, let alone an emergency care provider, and then a mid-level provider, whatever nomenclature we decide on, that doesn't have the voice to organize. And so how do we engage? What's the strategy to bring the structure that you've built to countries with a low physician density, whose patient population is accessing basically through acute care, which is going to be the system in place for longer than building primary care?
Can I suggest that we have a couple of people ask their questions, and then maybe we can respond to more than one at a time, since we're close to the end of the session? Is that okay?
My name's Joe Nimzur. My poster session's tomorrow in the afternoon. It's about the country of Nepal. I've been so sensory overloaded that I was snoozing back there until we got into the nursing and medical thing, and that perked me right up. I've enjoyed the focus of this, and it's been interesting because most of the presenters are kind of from African perspective. I work in an Asian country, and so much of it is about the role of women there and women's empowerment in terms of doing it. I'll give you one example of something, and I will keep this short, but I'll give you one example of something that totally blew me away when it happened. We had someone in Nepal, an academic critical care person, who decided to survey intensive care units, and the complete summary of their document, their study that they did, was who has mechanical ventilation, who can do intubation, who can use central lines, and all that stuff. And it completely ignored who had nurses that knew how to read a monitor, who had nurses that could interpret at a pulse ox value, and that sort of thing. And I think that in empowering women to be able to be active and to fulfill the role is just critically important. And I do think that that's a particular problem in Asia that I don't know anything about Africa, but I do think that's a big issue.
Hi, my name is Kirsty, and I'm with UCSF in the Masters of Global Health Sciences program. My question also has to do with silos, but not in the sense of where the conversation of emergency medicine isn't being discussed, but rather between partners or between potential partners where they're both trying to do the same thing, and how to overcome some of those barriers, whether it's they have funders or they think that their way is the way that it should be done, and how to form those sustainable collaborations and come over some of the resistance. So yeah, thank you.
Hi, my name is Obi from UCSF. So my question is from the bias of being a provider in Nigeria. So in Nigeria, you have a significant proportion of care being provided, emergency care being provided at the secondary level. And majority of that care is provided by the private sector, which is heterogeneous and usually not very well connected to policy or regulation. So my question is, how do you hope to engage the private sector in order to improve emergency care?
So I will comment only very briefly on one of them and then let the rest of the group, because several of these guys will have much better answers. For the low physician density thing, I think you have to just acknowledge that most of the care in the world, the emergency care, is not being delivered by doctors, and target all of your activities to that reality. So the basic emergency care course, has been our most recent thing on that. It's completely aimed at non-doctors and was piloted within that group. I think it's really just a matter of acknowledging that that is the reality all over the world overall, and behaving appropriately.
Okay. Which one? Okay, so I'll try to respond to the engagement of the private sector. So one of the things that's been really challenging, especially in Tanzania, is the role of private sector in providing emergency care. As you know, emergency care is very sort of expensive because patients show up, especially in Africa, with no insurance, and most of the time no money and no names are known. And private sectors are usually less interested in patients who have no money, at least in my country, because that's how they sustain their business. And so one of the things that has been going on in negotiations to make sure that doesn't go away is the agreement in the minimum amount of care that the private sector can provide to patients when they present with certain emergencies to save lives. That's the best model that I see can work in the country. Like, what is the expectation that the private sector will have? And there is a very hot negotiation going on right now between the Ministry of Health and the private sectors that provide healthcare. And we've been asked for an opinion in different situations as public sector, as an association, on what we expect the private sector to do. So realistically speaking, for many African countries, the best that we can do is to offer the private sector an opportunity to provide the minimum basic care to the patients without any expectations. And if there is an expectations, then that is a bonus. That's as best as I can say.
So I'm going to take the sustainable collaboration, because I think that's where a regional organization plays an important role. The first thing is that the pie is big enough for all of us. You know, there's enough development and research to go around in emergency care for everyone to have some part of it. But particularly when there are differing models, having a regional organization with a clear priority about development goals and research that projects can align to might be very useful. And AFM and WHO are starting to put out all of those things related to emergency care that hopefully drives all of these partnerships towards the same point. And you know, having an AFM-backed, and I'm speaking from the African experience, having an AFM-backed project probably has more, and the connections that it comes with and the networking might have some more value. And so if we use regional and international organizations as a mediator between academic institutions and offering share of a larger pie, that might be something that we can move forward with.
Yeah, I've said what Heike said on previous occasions, and it's referring back to Richard's talk this morning. It's utopia. We have funding bodies who talk about, we want to get this collaborative, like everyone doing the same thing, moving to the SDGs, and we're going to do that by a funding model that makes you compete against you, against you, and against you, and reward only one of you, and the rest of you are left to die. The model's wrong, the funding's wrong, it's driven by people with the right talk about their agenda and the wrong model to drive it.
Great. Listen, you guys, thanks so much for all the questions, for hanging around. Any of you who are interested in the WHO things, we have a website now, which is nice. That kind of URL meant a lot to me after 25 years of looking at WHO websites. So thanks so much for coming, staying over time, and we're happy to talk afterwards for anybody who has other questions. Appreciate it.